Good afternoon, everyone. Thank you very much for joining this lecture series, which is aimed to inspire our learners to reach their full potential. It's my great honor to invite Professor Rela to speak to our learners today. Dr. Rela, for those in field of transplantation and liver surgery, doesn't need any introduction, and I'm sure in his presentation he will tell you things which he has accomplished. I hope his talk inspires everyone like it has inspired me. Thank you very much, Dr. Mohamed Rela, and floor is yours.
Oh, hi. Thank you very much, Anwar. Should I call you Siddiq or Anwar?
Anwar, yeah, that's okay.
Hi. Thank you for that introduction. And um, this is today. You wanted me to talk about how got on actually in life, or where I started and where I went and where things are. And so I think start off from where I started my life and how liver surgery itself and liver transplantation itself, transformed my life. I mean, I use the word redeemed actually, because I always wanted to be a surgeon. Even before going to medical school, I wanted to be a surgeon. In fact, I wanted to be a urologist. As you know, I did my basic surgical training in India. And I was very frustrated, really, in India. So I went to the UK. I went to the UK in 1985. So that's almost, 40 years? 39 years now. So I think I've done surgery for more than 40 years, I think now. So that's what, so I came, I mean, I don't know, many of you may have come across Merchant of Venice, and this was a poetry that we had to memorize, and I gave this in the ILTS talk as well, because surgery is something, it's like, it's twice blessed. I mean, it blesseth the one that performs the operation as well as blesses the person who's operated upon. And this is about, I don't know if you remember in Merchant of Venice, this is Portia who's talking about Shylock who wants a piece of flesh. And she talks about forgiveness and how forgiveness, whoever forgives, mercy is twice blessed. So it was about the quality of mercy, and I've just taken this to say liver transplantation or liver surgery or even surgery in general, I think very much blesses us, or even doctors for that matter. I think the profession that we do. And that is, mercy is an attribute to God. I don't know, I mean, I'm talking to the Middle East. It's a quality of God, isn't it? Ar-Rahman and Ar-Rahim. So that is something that we are able to actually show that there is God in us, providing mercy or helping people, and it blesses the person who receives the treatment as well as blesses us as individuals to become what we are. So when you look at this child who's had a transplant, and this is before transplant, and how miserable the child looks and how unwell it can be, and liver transplantation changes life. This is only 3 months later, and how well the child can transform shows how what we are able to do can transform the life of people. And I put myself there when I was a young man, when I was a medical student, and that was in front of Taj Mahal actually, which with me now as a much older person, probably about I think almost 50 years older than when I was in that picture. So it does transform individuals. Just for a background, I come from a very small village in the south of India, and this is our village. That's our village pond. I started my basic schooling in this school, which was actually built by my grandfather, actually. I mean, it's now better. It doesn't look like this anymore. This was when I was a child. With a village school is where I studied and started my life. But I did come from a reasonably well-off family, and What you see there is my grandfather sitting with the leader of the Muslim League, that Indian Union Muslim League, and many of the political things happen in front of our house. You can see our house, which is really with a slate on the front, with the chief minister of that time giving a talk, and in the background on the left is my grandfather, who's standing behind the chief minister of Tamil Nadu at that time. So it's not that I come from a very poor background. I have had a very privileged background when I was a young person, and that was me being brought up. And my father worked in Singapore, and that's my mother. And we were six at that time, but totally we were eight. We had a twin soon after this picture was taken, and picture was taken in Singapore. So I have had a good education, good background, and they understood the importance of education and put me in a school in Chennai, which was very famous at that time. This is the current location of the building, because the school doesn't exist anymore in that side. They moved it to a different side. So that was our school building, and it was started by a very famous person called Annie Besant. She was a freedom fighter. She lived in Theosophical Society in Chennai. And it was run by Rukmini Devi, who was a very famous dance person, art person. So the emphasis was hugely on culture and art at that time as I was growing up as a child. And it was a residential school, and so we studied art and the general studies as well. And I don't know if you can see me. I don't know if the picture can show where I am. I think I'm here. I don't know if the arrow shows where I am. So that is the school final picture of me at the school. So from there, really, I always wanted to be a doctor, as I said, and I went into Government Stanley Hospital, which was in Chennai itself. It was the second, the best or the most popular one to go to was the Government General Hospital or Madras Medical College. But I went to the number 2 institution, which was Stanley Medical College. People may not agree Stanley is number 2, but I have to say probably Stanley was number 2. And soon after finishing MBBS, and I joined MS, but my frustrations of staying in India remained, and so I ventured to the UK and went to the UK, passed PLAB, and as soon as I got my MS degree, I think even before the final results came back, I went to the UK to do surgery, wanting to do urology. Struggled through. It's not an easy. For 4 or 5 years, I was mainly doing general surgery. I did a bit of vascular surgery. I did a bit of urology. I tried everything actually for 5 years, and finally I went in the UK. They have regional registrar interviews in teaching hospitals, and I was working in I was working in Kent, and the regional teaching hospital was King's, and I went to King's. And they asked me what I was doing in England for 5-6 years after trained as a middle grade registrar. They thought I should be going back to India. Then King's was famous for liver, and I said, okay, I'd like to do some specialization. I've not really, done anything that will identify me as a specialist, not as a general surgeon. So I said, give me an opportunity to do liver. And that's how I just went through an interview where they said, okay, we'll take you in for a year. And they took me in for a year, and then 2 years. And in 2 years, 2.5 years, I was a consultant in a teaching hospital in the UK. So I think if you can show your interest and your ability as a surgeon, it's not very difficult to come up in a specialty. So I went into King's in 1991 as a registrar, and then a senior registrar. And in 1994, I was appointed a consultant, and then in 2008, I became a professor of liver surgery. And then 2-3 years later, I felt that I had to move, and I came back to India. I worked with really pretty big people in King's, in liver, my colleagues Nigel Heaton, Julia Wendon. Julia Wendon was a specialist really for creating liver intensive care, and John O'Grady, you may have heard, is a hepatologist. the King's College Hospital criteria for transplanting acute liver failure was devised by him. And Nigel Heaton and I worked very close together. And Roger Williams was the boss at that time. And when I went to King's, Casey Tan was the head of the unit, and then he left for Singapore very quickly. So this is Anil Dhawan, you may know, he's a very famous pediatric hepatologist. So I had an opportunity to work with some pretty big people. Bernard Portman was a liver pathologist, was a world-renowned liver pathologist. And Roger Williams, as you all know, was one of the biggest of the hepatologists in the world at that time. And one of my friends was Paolo Moizan, who's no more. I'm just putting that in memory of him, really. He was a friend and a colleague, and he died 2 years ago of brain cancer. So they've been good. And subsequently, really, Mr. Tan also died in China. But he left King's many, many years ago, 30 years ago, and established a program in Singapore. So he was one of my mentors. And nothing could have happened without the support of the family, really. That is my wife. And I have to say, when she got pregnant, I sent my wife back to Chennai because the job was very busy as a registrar in liver surgery. And in fact, I saw my daughter only 3 months later after she was born because I felt I couldn't look after. I mean, that's a very irresponsible thing to say, but that's what happened. And that's my daughter and me when she came back to the UK. So that's life, and I think I'm very proud. And we have brought up 2 children. Both of them are girls, and both of them are doctors. The older one is training to be a vascular surgeon now, and the younger one has just finished her MBBS. So that's us as a family, side by side, going on with it. Now, what made me unique in King's was really my interest in pediatric liver transplant. I think everything happens as a chance. I mean, I went to King's asking for a training in liver surgery, and King's was really quite a big name for liver transplantation. And it was also a big name for pediatric hepatology. So everything was a chance. And I wasn't a pediatric surgeon at all. I wasn't a trained pediatric surgeon. But I got into pediatric transplantation and had an interest in it. And there were many problems that needed to be sorted out. And this gentleman, Professor Alex Mowat, was the only professor of pediatric hepatology in the world at that time. So there was a huge number of pediatric liver patients who came to King's. And we had an opportunity to really develop the field of pediatric liver transplantation. And these are the people. Really, it was Nigel Heaton and me on the surgical side, and Professor Mowat, Anil Dhawan, and Georgina Mili-Vargani were the pediatric hepatologists who were really world famous. And we were able to build a big pediatric liver transplant program. Now, at the same time, really, I had friendship with Professor Tanaka, who used to come and visit us. He's retired now. He had an interest in pediatric living donor liver transplantation, and I took an interest in that, really. And he became a good friend, and he's been to Chennai. He's been to my house as well, and he was, I would say, one of my mentors in the interest in pediatric transplantation. And if you look at this slide, from the time we started to now, the outcome of pediatric transplantation over the decades really has improved. I mean, I went into, in the second curve is when I went into pediatric transplantation, and now you can expect a 96% to 98% survival after elective pediatric liver transplantation. So the field has improved, and I also took an interest in split, and at that time, the Europeans were much, much more aggressive with splitting livers and transplanting 2 patients. And these are the people, Jan Leroux and Professor Ott. Belgium was one of the important places where the developments of split liver transplant took place, where I learned from. Now, my next interest was really improving organ donation and in transplantation, and this was the early days where only whole liver transplants were done, and in King's we developed and promoted really the technique of split liver transplantation, where the left lateral segment was transplanted into a child and the right lobe was transplanted into adult. And this was a leading article written by me and Nigel in the British Journal of Surgery in 1998, where we could show really, and we had an Annals of Surgery publication as well, where we could show that the survival of split liver transplant was not inferior to the adult patient receiving a whole liver transplant. So that, if you look at the last one, the last paper, so the graft survival and patient survival was 90% and 88% for the right lobe, and for the left lobe it was 95%. And that is a significant improvement from what others reported over the years. So our program really has been able to show that splitting a liver does not harm the recipient who receive a partial liver. And these were before the days really of living donor liver transplantation. And there were many techniques that we were working on, one of which is called an uphold, which is an auxiliary liver transplant for acute liver failure. And this is a surgery which is done to prevent patients from being on lifelong immunosuppression. Acute liver failure patients who receive an uphold graft can be withdrawn from immunosuppression because their native liver is able to regenerate. So here you have the large graft, which is a left lobe, which is to make the patient survive, and there is a small liver on the right side, which is a native liver. Over a period of time, you'll be surprised to see on the CT scan that this small right lobe will start growing slowly, and this one, when you start withdrawing immunosuppression, will slowly start rejecting and will become smaller, and the whole thing will reverse, and when it reverses, you can stop the immunosuppression for these patients. And we had one of the largest experience at that time of auxiliary liver transplantation, actually, in general, and also in acute liver failure. And this is, again, an Annals of Surgery publication on showing that a significant proportion of these patients could be taken off immunosuppression. And this is the picture of the same patient. You can see the first CT scan shows the right lobe, which is a native liver, is small. The left lobe with the graft is big. And over the next 6 months to 1 year, the native liver starts to grow, the graft begins to shrink, and about 1.5 to 2 years, the native liver is fully grown and the graft has become very small. And these patients can be taken off immunosuppression. And these are children with a long life expectancy, and not to have immunosuppression is a very important thing. And we also tried this on metabolic liver disease. The principle of doing auxiliary liver transplant for metabolic liver disease is not to withdraw immunosuppression, but we were told at that time many metabolic diseases are going to be cured with gene therapy. And if gene therapy were to come, then patients need their native liver, which is why we did auxiliary liver transplant. This is almost 25 years ago. And the people working on gene therapy at that time told us it's just round the corner. This was a publication in 1999 in Annals of Surgery. That's almost 25 years ago we published this. And still gene therapy is not there. And a lot of these children are not stuck. They have an auxiliary graft, but with no opportunity for a gene therapy yet. But having said that, I mean, science develops over a period of time, and these are very young children. They are probably now 25 years to 30 years of age, and if they have a life expectancy of 60 years, who knows, in another 20 years' time, if they can have gene therapy, it will still be a useful operation that they've had. Now, the next interest really was transplanting very small children, and I took an interest in that. Again, this is publication in 1997, which is this is about 27 years ago, where when we looked at the outcome of transplantation in very small children, under 3 months of age, almost 50% of these patients were dying at that time. And part of the reason is the very small children needed a very small amount of liver, and even a split liver was too big for them. And then we developed the technique of what is called a monosegment. You can see the size of this child's abdomen and the size of my fingertips. So this child is a newborn, less than 1 month of age. And we had a good experience in transplanting children in the neonatal period. And we developed really techniques for safely transplanting the neonates. And here you can see once we reduce these livers further reduced into a monosegmental graft, either 2 or 3 monosegmental grafts, then your survival improves. So out of 6 children here, 5 are alive. And these are all mainly acute liver failure in small children. So one of the surgeons who worked with us at that time as a fellow was Kasahara. He's a Japanese surgeon. He's now a big professor, and he really developed some techniques in the field of neonatal liver transplantation. And he was kind enough to really describe further techniques and include me in his publications for having worked in the past with me. And he says that a lot of the techniques were what he's learned was from King's College Hospital. So this is how the story goes, really. The youngest child ever to have a liver transplant was at 5 days of age with the congenital hemochromatosis. That child also had to have a PDA close at the same time, had a patent ductus arteriosus, so you can see a thoracotomy as well. And that was the size of the liver. This is a video of, it became quite a, because it was the youngest child ever, it was an important event, and all the newspaper and media were actually were very involved, and it came out really on all of the newspapers at that time. I move on. I don't know how good videos are going to be played, but this girl has grown to become a normal person. This is immediately after the operation where it came out there, and this is 5 years of age, when the child was 5 years of age. There is another girl there. This family lost 2 children to congenital hemochromatosis. They had one normal child, and this child also had congenital hemochromatosis and had the transplant at 5 days of age. So this other girl became a doctor, and the 5-day-old transplanted child is now a lawyer actually in Ireland. The family was from Ireland, and this is the same child at 5 years of age. And this is the same girl when she was 22 years of age. When I went to London, I met her. This is Anil and Georgina, who are looking after her for many years. And she's never had a CT scan. She's never had any major investigations, really, ever since she had a transplant. And when I met her, I said that, can you come to Chennai, to India? Because in India, it was also at that time very difficult to convince parents that children need transplant, because the cost factor is one of the big things in India that people generally can't afford. The second one is whether they believe that these children are going to be normal. I think even the medical profession sometimes don't believe completely that patients who have had transplant can lead a completely normal life. And somebody like that, I thought, coming and saying that, I had a transplant when I was 5 days of age, I'm 23 and I'm a lawyer, or I'm studying to be a lawyer, I thought would be a huge boost for the field of liver transplantation. So she did come to Chennai to one of our big meetings and met the medical profession there. And this is the international faculty. Most of them are dressed in South Indian attire. So when we had this function, actually, the Chief Minister of Tamil Nadu found out about it. My colleague Nigel Heaton's also there. Anil Dhawan is there, and many senior hepatologists and surgeons from around the world were there. And the Chief Minister wanted to have a function and to meet her. So the Chief Minister met her, and they were pretty impressed how somebody at 5 days of age could look like that. I mean, all of the result of all of this is the government is keen on, in India, the cost is an issue, and in Tamil Nadu, the government funds transplantation and provides most of it. I think fully funds actually transplantation, especially for children. They're very, very good. So I returned to England. I'm returned back from England to Global Hospital Group to begin with. I worked there for 10 years, and then subsequently we moved to our own institute, which is not just for liver, it's a general hospital, but 50% of the work done here is still liver work. And I say to people, the success is about developing a team. This is just the liver team, liver doctors and nurses and anesthetists having a really time off in a resort in Tamil Nadu. So that's what I'm proud of, that I've been able to really build a team which is as good as something in the West, which is as good as what we have achieved. And also to financially develop something like that. This is our liver intensive care, you can see, which is one of the best in the world actually. People from around the world have come and seen our liver intensive care and said, in terms of how well it's designed and how aseptic it is. But I keep telling people, it's not about money, it's not about funding to develop or build a hospital, because that is important. But you could have all the money you want, you could build the biggest institution you want, but if you don't have the right team and don't have the right people, you can't make it a success. I believe that people are more important than institution to make it a success. So when I was in India, when I came back, it was just developing actually liver transplantation. And Liver Transplant Journal asked me to write an article about the status of liver transplantation in India. Compared to that, 12 years later, I think India has progressed very rapidly. The opportunity in India is huge. If you look at the rank India in terms of organ donation and transplantation from around the world, I think United States obviously is #1, performing about 9,000 transplants. China is #2, performing this liver transplant, 5,800 transplant. But most of the Chinese transplants are really cadaver liver transplant, and India is #3, and now we do more than 3,500 transplants. This is 2021 or 2020 statistics. So India is really progressing pretty rapidly in the field of transplantation. The number of transplant centers in India have also gone up now. I know there are about 230 transplant centers, but not all of them do big numbers. Many of them only do about 5 or 10. But there are about at least 10 centers who do more than 100 liver transplants, and we do about 300 liver transplants a year. And academically also, India has not done too badly in terms of publications in the field of liver transplantation. India is doing well academically. I think India is being recognized as a good country in terms. And I was elected as the president of Liver Transplant Society 3 years ago. Now I'm the past president. And there are many of my colleagues in India who are involved in ILTS and in the international scene. So that is quite nice to see that India's progress. Just for a comparison, if you see how the number of transplants in India has gone up in 2023, we did 3,700 transplants. The lower graph in blue is actually UK numbers. The UK numbers over the last 10, 12 years has gone up from somewhere around 670 to around 900. That is a growth prospect of liver transplantation for the UK, whereas at the same time we started off with 200 in 2010 for the whole country. That's when I returned to India in 2010, where the whole country was doing 200 transplants, and now we are doing close to maybe 4,000 liver transplants per year. And in our center alone, we do more than 300 liver transplants a year. And since coming back to India over 10 years, 12, I think almost 13 years now, I've done over 3,000 liver transplants. We not only do LDLT, we also do DDLT. Our center has done more than 500 DDLT as well. And the outcome has been good. And we are also one of the largest centers in the world, actually, apart from Chinese centers. We do the maximum number of pediatric liver transplants. We have done more than 665. This is only till September 2023. Last year also we did over 100 pediatric liver transplants. And this year we'll continue to do that sort of numbers. So pediatric transplant has been my interest from King's days. And I've been able to really replicate what I've done in King's in India as well. When we had our 500 pediatric liver transplants, in Chennai, we invited the ministers, the government ministers, to have a look at these children because they were funding a significant proportion of these children. And for them also, I told you at that time, the chief minister saw that girl who had transplanted 5 days of age, and to see our own children transplanted in Chennai, looking so well after transplant, you can't never recognize that these are children who had liver transplant. I think that boosts and makes the health ministers there as well, makes them think that it is worth spending money for this group of patients. And I've been well recognized after coming to India. I've been given the Lifetime Achievement Award from our medical university, as well as DSC by one of our previous chief minister, who's no more. We have been very academic, conducting meetings, and you're all welcome. We have this annual meeting where over 1,000 people attend our liver meeting, which is called Masterclass in Liver Disease, and we have many international speakers from all around the world coming to this meeting. Some of the top liver surgeons and top hepatologists have been part of this meeting, and they've all really helped to help with the academic exercise here. And last year we had a consensus conference on living donor liver transplantation, and you can see that every big person around the world involved in the field of living donor liver transplantation was there. And at the end, in the consensus, after the consensus meeting, we had 5 publications in the Transplantation Journal on the consensus subject matter. So that was a hugely successful 5 publications out of 1 meeting in the journal, Transplantation. As I said, I was elected as the president, I think the first Asian to be really elected as the president of International Liver Transplant Society. This is a little old actually. My H index is 72 now. I have more than 650 publications and close to 20,000 citations. So even after returning to India, which was one of the criticisms of my colleagues when I was in the UK, that if you go to India, academically you wouldn't be able to perform, but that is not true. In fact, I've done academically better after coming to India. Just to finish off, I mean, I'm getting old as a surgeon, and people say, how long can you be developing things? I went into a consensus meeting of surgeons who do minimally invasive surgery, and they invited me as a jury, or as a surgeon who does not perform minimally invasive surgery, donor hepatectomy, just as a counter argument. And there are CM Lowe and I were probably on the opposite side, only to look at the interest of the public and to see if there is safety involved. And after that meeting, we had this. This is just before. This is before the COVID, and I was pretty convinced that the way forward for donor hepatectomy was minimally invasive, and I felt that the robotic platform was probably better, and so we got the Da Vinci Xi system during the COVID, and I did a lot of training because we had plenty of time. The COVID was not a busy period for transplantation, and really we got into, I don't know if I will show you the video. Is it coming?
Yeah, video is working. Yeah, video is working.
Yeah, the video is working. I'm nearly done. Can I take another 5 minutes or so? Is that
yes,
okay?
Yeah, you have time, doctor. Thank you.
What time is it now?
So we have 60-minute slot, but you can take as much time. Thank you.
Okay.
We've got 40 minutes left.
Oh God! So I've only taken half an hour. I thought I've been talking for a long time. So this is the robot, the liver left lateral segmentectomy. We started in terms of safety as only to do pediatrics because we do a large number of pediatric transplant. That is the left lobe which is being mobilized. Is the video very jumpy or is it okay?
It's working fine, Prof.
Okay, thank you. So that is a hilar dissection now, and all the tissues are being taken away, and you'll find that I'll mobilize the left side of the hilum, isolate the left hepatic artery. So just slowly taking away the tissue will expose the hilar structures. Are there many surgeons in the audience?
I don't think so. It's mostly for physicians. Mostly physicians.
Okay, all right. So I won't show too much. I'll just skip a little bit. So you can see the surgeon is not actually handling these instruments. I mean, the surgeon is actually sitting in a console far away from the patient, and his movements are transmitted, and it's much more accurate actually. So I'll move on. So this is how the robotic surgery is being done, and we published our experience of 75 robotic donor hepatectomy, where really the outcome complication rate were not inferior at all to open surgery, and our learning curve was very short really in terms of the time taken. After the 20 cases, the time taken was similar to that of open surgery, and we have done even the neonatal transplants, the monosegments using the robotic surgery, and now we have totally done in 3 years 270 donor hepatectomies. I think especially young people who are less than 30 years of age or unmarried young women donating for their 50, 60-year-old parents. When they are donating, we find that young girls who are about 20, 21, who are not married, have a big abdominal scar. I mean, previously we used to do a reverse L scar, now we do midline scar as well. And they find it difficult to get married subsequently. So you can see the difference in scar. This young man was very conscious about his looks. Wouldn't have had the operation if it was not for a robotic donor hepatectomy, compared to a big L-shaped scar, or even if you do a midline scar. It really is not cosmetically a nice thing for somebody who's trying to help somebody else. Whereas with the minimally invasive, whether it's laparoscopic or robotic, I think it's a huge advantage for these individuals. And finally, I think we are extending the donor operation to the recipient. You might say, is there a role for recipient? I think that is debatable still, but I think the recovery and the trauma of surgery would be much less. Here you have the recipient hepatectomy being performed, and that is called ICG, the color. That is an advantage in the robotic. Now the hilar dissection is being done. In spite of portal hypertension, I think we can do a bloodless operation robotically, and that's a bile duct which is being slung, hepatic artery which is being divided, and I'll move on a little bit. So the liver is about to be taken out, stapled hepatic veins. And that's it. So the entire procedure being done robotically. This is not donor operation, this is recipient operation. And around the world, really, this has not been done. It's in Saudi Arabia, Data Growing has started doing it, and we are starting to do it. Through a small incision, you have to take it out. This I don't do through a fan and steel until I'm very confident that this can be done without complications. So that through that small hole, you insert the graft inside, and once the graft is inside, you start the implantation. And here you can see the implantation. And robotic is almost like open surgery, how we can suture things. It's very different from laparoscopic surgery. The suturing technique is much more advanced than the laparoscopic technique. You can see. I mean, you can't imagine that this is being performed by a robot. Actually, it looks like the instruments are in the hands of the surgeon. In fact, the instruments are not in the hands of the surgeon. So I think in the future, robotic will replace many surgery, including even advanced laparoscopic surgery is not going to be done. This is a portal vein, and then at the end of the portal vein, the liver is reperfused, because there are not many surgeons. And even small arterial anastomosis can be done robotically. This is a 3 millimeter artery, and I'm performing the arterial anastomosis robotically. So I'll skip to the end of the anastomosis. That's the last 2 bites. And the clamps are being opened, and you can see the pulsation in the artery. And bile duct anastomosis done in a very similar way. So this is what you're left with, a liver transplant operation done through a small midline operation compared to a large reverse L big incision. And I believe even recovery is going to be smooth when operations are done like this. So that's how it is. I think that is the story of my life, of where I've come from and where I am at the moment. Starting in a small village in India, moving to Chennai, which was a big thing, and being restless in Chennai and moving to UK in London, and being restless in London and coming back to Chennai, where I'm originally from, and showing to the world that we can do outstanding work anywhere in the world as long as the quality is maintained. Thank you very much.
Thank you for this amazing lecture, telling us about your life story, Prof. Um, if the audience, if they have any questions, could you put them in the Q&As, please, and I'll put it to Professor. Prof, I have a couple of questions from my side. As you recall, the discussion we had initially when we came to Abu Dhabi for this lecture was, how do we train the doctors of the future? As you know, mid 2000 onwards, it was somehow that medical training switched to competency based versus excellence based. Now, from your own career, you have set up different programs and now set up a hospital in India. And this is more than just simple project management. You learn end to end. Um, what has happened? What do you think the medical trainee should be thinking about when they're planning their careers, if especially if they want to be doing things which you're doing, not just in neurotransplantation, in other fields?
Yeah, I think that's a good question actually. I think competency is very important. I think that's the route the Europeans have taken, the UK have taken, because everything is about competency at the moment. And that is what will provide with safety for patients. Not everyone is able to exceed, or, you can't achieve excellence in everyone. But when you're running, say, a health service or even a hospital that I run, I mean, I think it's good to have excellence, but you have to have competence. People need to be trained, they have to be accredited, they have to be able to do something very safely, and they have to be answerable to the work that they do. I think competency is very important. But then, if you take it too far, that everything that you do has to be structured and everything has to go through a committee, and if you've never done one of the problems I had, I'll tell you, which is very relevant to this. We started doing splits when nobody was doing it. We started doing auxiliary liver transplant when nobody was doing it. Neonatal transplant was not, you can't go and learn and come. So I've been going through that phase, and I went through UK system where slowly and slowly there were committees which developed, and then they have new and novel committee, and then I wanted to do living donor liver transplantation, and then they will say you have to go somewhere where it's being done, which is okay, but and you have to done this much, and now we've got rules for everything, but this necessity for competency in anything that you would like to do will kill innovation. How does innovation come? Innovation, when somebody is innovating, when somebody is doing something new, you can't go and tell him, find out from somebody else who's doing it. I mean, how did that person started doing for the first time? And when you want to do something for the first time, are you allowed to do that? That's exactly one of the reasons I got started becoming frustrated in the UK, that in the UK there was no more place for innovation. It's all about competency, safety, how you do a good job. And if you put your head out, and if something goes wrong, there was nobody to really even protect you and say, you've done the right thing, but unfortunately things have gone wrong. And if your own colleagues won't support with excellence or innovation, it becomes a problem. I mean, that's my view, but I'm not against competency as a way of running health service.
Yes, I think the question is more not, of course, the healthcare service will benefit from competent doctors, but from an individual level who the residents who may be like more than average, who are the trainees who may be more than average, how do we nurture them? And that was the question about. And thank you very much for sharing your experience. Um, can I ask you a question more relevant to people my age, who are mid-age, mid-career, and you made a jump from King's College, you had a secure job, you were a leader then when I first met you in the UK, and now you took many risks, presumably financial risks as well, to come to India where nothing was there yet. Like, what from your own personal experience, what kind of tips would you give and share your learnings for someone who's trying to attempt that?
Yeah, I think you have to have an element of risk taking. I mean, people say that I didn't take a huge risk because when I decided to come back to India, I took a 1 year sabbatical because I wasn't sure whether I would like. And many people told me, knowing your personality, you may not get on in India. It's very businesslike, and you won't do well is what people frightened me with, and therefore I took the sabbatical. But I finished the 1 year sabbatical and went back to the UK and worked for 3 months and felt that I could not work there anymore. I think you just have to follow your passion wherever the place allows you to do what you want to do. I think you need to take the risk. If you never want to take a financial risk, you're never going to, excel. If you never take a risk with your career, you're never going to excel. But you have to have confidence in yourself. I mean, there are many people who came to even from the US and the UK who came back to India and left within 6 months because they were not able to manage in this country. I think people who are good, competent, want to, carry on and face the difficulties, there is a huge opportunity. I mean, I'm from India, and I'm lucky that there is a huge population here, which requires treatment. I came back to my own town, so in that way, I didn't take huge risks. If I had gone to Bombay or Delhi, maybe I may not have got on well. When you come back to your own city, your own people, and people still remember, or even people who don't remember you will say, I remember him from his medical school days. So I had that huge advantage that people have accepted me with open arms, and people have accepted that I'm doing a good job. And I've also worked hard and shown to people that I'm able to do a good job. So I think you have to have an element of risk taking and follow your passion and go where you can achieve excellence.
Thank you.
I
Thank you,
have to
Prof.
say, if I had remained in the UK, I wouldn't have been as prominent as I am today. I've no doubt about that. Yeah, I would have been a consultant in King's College Hospital. I would have been professor of liver surgery. By now, I would be thinking about retiring. Which is what's happened to my colleagues.
Prof, one last question. I mean, I'm kind of interested in how to build successful teams and teams which are working towards, like not just routine day-to-day work, but actually aiming for excellence. For that, you probably need to have, not just one Messi in the team, but multiple Messis in different domains. How do you create that team, and how have you created a team?
Yeah, when I told you I was in global hospital program, and when I decided, again, I moved for various reasons that I wanted to be independent. I wanted to be able to make financial decisions. I wanted to, treat people if they didn't have money. I didn't want people to be asking me questions. So that's why I'm not a great businessman, really. I mean, I've been successful in the business, but I don't have that corporate attitude, and one of the reasons why I went. And when I moved, you'd be surprised to hear 270 people moved with me when I moved from Global Hospital to the current institute. And a month later, another, I think totally more than 350 people moved with me in 1 month. And how did this happen? This is a question. How do you retain people? I think, first of all, people had confidence in me that I won't let them down. And Because you could say they may be taking a financial risk as well to move with me, and if I don't succeed, all of them wouldn't succeed. So they had confidence in me, and it's really keeping, and all of them really, I think, except for one or two, most of the people who came with me, especially the liver guys, are still with me. I would say 80% of the guys who are with me now have been with me for more than 10 years, other than the trainees. It's giving them the opportunity to grow. It's giving them the opportunity to learn, and an opportunity for them to show who they are. And I think once they stop growing, they won't be with you. And very ambitious people also won't be with you. I mean, I'm not saying they're not ambitious. There are people who prematurely want to start something on their own, and they leave, and you will find that some of them will succeed, some of them won't succeed. But as long as people feel that they are continuously learning and growing, and if you give them that environment to learn and grow, I think people stay with you. And once they stops, they're going to leave you.
There's a question from the audience. I think so. Someone you know him well. He asked, did you have to design specific robotic instruments / hands for transplant work, and do you use lab? I'm going to spell it. I don't know what this means. CUSA.
Yeah, he's a surgeon, obviously. I haven't developed, and the company has been gathering people, because the robotic devices have been developed for pelvic surgery mainly, urologists and really the oncologists, pelvic oncologists, the ones who started using. I think the very early time they were using it for cardiac, but they've given up on cardiac as well. So actually there can be a huge improvement. There can be an improvement in the instruments which will come, because the company has not been focusing on liver so far. There are no specific instruments for liver, but we are still able to manage with the current equipment they have. With respect to the CUSA, that's a device which is used for transecting the liver. I mean, I didn't show it in the video. Our surgeons are very good laparoscopic as well, so we do a laparoscopic CUSA, not a robotic CUSA. Robotic CUSA is under development. The company is saying that the robotic CUSA will be ready maybe in 1 or 2 years, but we feel very comfortable to use a laparoscopic CUSA currently.
Prof, I want to ask you related to that is I'm interested in micro learning and concept of unlearning and learning new concepts. I mean, you learned robotic surgery looks like later stage of your career. And as you know, in healthcare, largely learning one skill and being master it has been encouraged, not learning new skills. How did you what and learnings you have to share from mid-career physicians or senior physicians that you can still upgrade yourself, upskill yourself?
That's an interesting question. I was actually talking to my team in theater today. We were doing a pediatric transplant, and how if people who've been working with me 10 years ago come back and watch me operate, they'll be surprised to find that I'm operating completely differently. The people in King's, if they come here, they will see that they probably would still be, the people I trained would still be doing the way I was doing 10 years ago, but now I do it very differently. So I keep moving on and learning as we learn, we keep moving on. And I believe that the way I operate, the way I do things keeps on evolving over a period of time. And even though for me it doesn't look very different, for people who have worked with me in the past and who come back and see me operate, they always say, oh, you're doing this differently, you're doing that differently. So I think we have to have an open mind, and otherwise I would have never taken on robotic. One of the reasons I took on robotic, I was never trained as a laparoscopic surgeon. So I always had this apprehension that I have to go back to learn from the basics. And at my time of my career, I don't want to be going to, laparoscopic training center to do a cholecystectomy. So that was never a possibility. Robotic is a new field. So I started, and the laparoscopic liver surgery never developed for some reason in our unit, because the more junior people will never do something if they think there is nobody to rescue them if they got into trouble. So the boss was not doing laparoscopic surgery. even though I was encouraging, had the equipments to do laparoscopic liver surgery, the second in command, the third in command, didn't really take it on in a big way. They started, they were doing a little bit of this, little bit of that, never really progressed to a level that I wanted it to. The moment I took on something, and that gave them the confidence, now everybody is doing robotic liver surgery very comfortably. So if I didn't learn robotic liver surgery, we would have never developed robotic liver surgery here. So I think age is not an issue for anyone. And I think if you're a competent surgeon, able to do, in fact, I would say it's easier for the more experienced people to learn newer techniques rather than the younger people learning newer techniques, because we have seen it all. We have seen all the anatomy, we've seen all the variation. So the chances of me making a mistake with robotic, it's only the technique I have to learn. Whereas somebody who's learning from new will have to learn the technique as well as the ins and outs of liver surgery, which I've already learned. So I think I found it very easy to learn new techniques.
Thank you, Prof. We're running out of time, and it was a wonderful talk, and I hope the audience enjoyed this. I think the key message is, unless you're top of your game, you can't get other smart and bright people to work with you and innovate group, as a group. It was a lovely talk, and I'm going to share the recording with my residents. And thank you very much for your time today, Prof. Thank you. Have a nice day.
Well, thank you. You've
Thank
been
you.
very
Bye-bye.
kind. You've been very kind, and thank you for the opportunity to
Thank you.
share
Thank you.
my life, actually. Thank you.
Thank you. Thank you. Bye-bye.
All right.